everyone, and welcome to tonight's webinar on biopsychosocial innovations and community partnerships. Before we begin tonight, I'd like to take a moment of silence to acknowledge some breaking news out of Texas about another act of egregious violence against, in this case, school children, teachers, educators. I don't know if there's many words, honestly, to express the shock of this, but I'd like us to just reflect for a moment on the gravity of this and looking towards healing in our communities and in our society. So we'll take that moment of silence now. Thank you. So tonight we are here. Actually, let me back up. So my name is Leah Hill, and I serve as the clinical engagement specialist for the adolescent and young adult program at Strong Recovery. And it is my pleasure to serve as tonight's moderator for our conversation. And we are so fortunate to have with us tonight a panel of 6 exceptional providers and professionals who will share on their experience with utilizing the biopsychosocial approaches within the community sectors that they serve. Our webinar tonight is part of a series of presentations celebrating the Department of Psychiatry's 75th anniversary. And if you haven't already, we certainly encourage you to explore our 75th anniversary website for more information on upcoming webinars and other celebratory activities. So we'll begin tonight by playing a 25-minute video highlighting each of the panelists, the specific work they do in their respective community partnerships, and the role played by the biopsychosocial innovations within their work. After the video, I will pitch about 2 to 3 rounds of questions for our panelists before opening the floor to a discussion with you, the audience. So you all play an equally important role with us tonight in this conversation, and we welcome you to engage by asking questions, which you can do at any time by writing them in the Q&A chat box below. Your questions can be general and open to the panel as a whole, or you can address them to specific panelists. When the time comes, I'll be fielding questions or comments in the Q&A box with the panel. So before we begin tonight, I'd like to briefly reflect on the biopsychosocial legacy. Doctors George Engel and John Romano's development of the biopsychosocial model here at the University of Rochester revolutionized how the biomedical community approached the delivery of patient care. Its inception created a shift in focus toward making a more holistic, compassionate, and comprehensive approach to address the biological, psychological, and social factors that influence patient health. So this transitioned care delivery toward improving health outcomes with a more patient-centered and humanistic approach. While this innovative model continues to be a crucial framework employed in the treatment of patients within our clinical settings, it has evolved most critically to also inform the care we provide more broadly to populations and settings within our community. I'd like to thank the 75th Anniversary Committee, and notably Zena Schuber, Director of Community Relations, not only for their hard work and dedication in planning and executing these webinars and celebrations, but also for recognizing the crucial role our community partnerships play in the care of our diverse populations of patients and families that we serve. With that, let's roll the video of these exemplars of innovators in community partnerships who will tell us about the past and future of biopsychosocial innovations and how these can improve mental health outcomes in our beautiful, diverse, and complex community.
Well, it's very good to have you join this webinar tonight, and I look forward to talking with you briefly about what we've done in public health and preventive psychiatry and how this is fundamentally tied to working hand-to-hand with members of very diverse communities. I think first the best thing I ought to do, though, is to sort of explain what public health and preventive psychiatry is, and I'll use some comparisons or analogies. When we think about heart disease and we think about heart disease prevention, we don't wait until someone comes with the ambulance blaring into the emergency department, hand holding his chest, for example, and pain radiating through to his back. What we do is we look for people when they have asymptomatic high blood pressure or elevated triglycerides, and we try to treat people before disease begins. Maybe those are the earliest markers of what could be disease, but indeed it hasn't affected function or well-being. In fact, many of these things are silent. So in psychiatry, we've never had preventive psychiatry in the way they have preventive medicine. So part of our task is really to think about how to develop preventive psychiatry. Now, public health really involves populations as well as individuals, really looking for groups of people or communities where there's evidence of elevated risk or needs for intervention or problems. And it may be defined by zip codes, it may be defined by geography. There are any number of ways that we can think about this, but it entails actively reaching out, actively making partnerships, and working in an integrated fashion with different members of communities to be able to engage people who otherwise wouldn't come to our clinic doors. Indeed, if we think about the sort of nature and the sample bias of clinics, we wait for people to come to us, and in public health, we go to them. One of the examples of public health and preventive psychiatry was something that we did collaboratively with the US Air Force. My colleague Yeates Conwell, who was contacted in 1997, and given his interest in older individuals, passed this one off to me. And in 1998, I started making relationships with individuals in the Air Force and negotiating with them about evaluating their suicide prevention programs. Together with a colleague named Carrie Knox, who I sort of drew into this, we developed a process to work with the Air Force over what really was an extended period of time to assess whether they had made a difference, and indeed worked with the Air Force to define all the community partners that were involved and meet with them and get around a table and really talk about the nuts and bolts of the different elements of their broad Air Force community that they had brought to bear. But this ended up being a model for our kind of community collaborative, showing that together in a rigorous way that we can evaluate what makes a difference in people's lives and show that the Air Force in a sustainable fashion from about 1996 to the late aughts, 2007 or 8, really had programs that prevented suicide and overall improved the mental health of airmen. And that goes for airmen, which include men and women both. So if we think about this then, and we sort of put the prevention and the public health together, it's really about focusing on different groups. You could be defined by age, across the life course, sex, gender identity. It could be defined by ethnicity, race, or other kinds of things. It could be family focused. And certainly it's tied to communities. When I think about this, I especially think about the different settings in which we might encounter different kinds of folks. Could be the courts, schools, elder centers, recreation centers, the streets, any place where we could find individuals who need our interventions or need engagement. And indeed, it's engagement which is so critical in prevention. When someone comes into our emergency room, in some ways it's too late. It's a failure either of early intervention or preventing relapse. So we need to find ways of going out and identifying these individuals. And we have to overcome the barriers that they don't all have diagnoses and diagnostic codes. They don't all have procedure codes or could be billed by fee for services. So a fundamental challenge is how do we pay for these things in a way that is sustainable, is practical, and makes a difference in people's lives. And you're going to hear about a lot of these efforts tonight. And I'm pleased to be able to have worked with all of the individuals involved in these new adventures and exciting opportunities.
Good evening. My name's Yeates Conwell, and I'm very pleased to be part of the panel tonight to talk about the biopsychosocial innovations and community partnerships that my colleagues and I have been involved with for a number of years, trying to improve the mental health of older adults and preventing suicide in later life. Let me give you some background. Older people are the fastest growing segment of the population. They have high rates of common mental disorders and of suicide. Older people who attempt suicide are more likely to die as a result because they're less physically resilient in part, and more likely than younger people to use more lethal means like firearms and more lethal intent and planning. We've long argued that these characteristics of suicide in later life indicate that when an older person develops suicidal thoughts, aggressive means are absolutely needed to prevent progression to an attempt, because death is so much more likely to be the result. And even further, we need to intervene early to prevent the older adult from becoming suicidal in the first place, because by then, the horse is out of the barn, so to speak. We call that upstream prevention. There are several well-established factors that contribute to suicide risk in later life. I call them the 5 Ds, as depicted here: depression, disease or illness, disability, deadly means, and disconnectedness. It's this last one, disconnection from the things and people that give meaning to the older person, social isolation, loneliness, loss of independence, relentless stressors associated with aging, that led my colleagues and me to collaborate with non-medical community agencies such as Lifespan to form the Senior Health and Research Alliance. The SHARE Alliance, as we call it, was initially created as a partnership of Lifespan, our area's largest aging services agency, along with ElderSource, their joint venture with Catholic Family Center's Aging Services Division, to identify needs of older adults in the community. And lastly, PeerPlace, which is the platform for electronic client record for aging services agency clients in our region. Our goal was upstream to improve the well-being and prevent suicide by addressing disconnectedness in older adults. Why a partnership between healthcare and community-based social service providers? Well, these were our premises. Although social determinants of health have received a lot of attention in the last several years, it's clear that healthcare providers ordinarily do not have the knowledge and skills, the time, or access to resources necessary to effectively manage the social dimensions of care. In 2011, the Robert Wood Johnson Foundation had a poll of primary care physicians. It's showing that 80% felt they lacked confidence in their capacity to address their patients' social needs. Over 80% agreed that addressing their patients' social needs is as important as addressing their medical conditions. And 75% stated that their patients' unmet social needs often prevented them from providing quality care. They wanted to be able to write prescriptions for social services. Well, aging services providers are the experts in addressing social needs of older adults. The scope of services that Lifespan alone provides is extraordinary. We're very fortunate in our region to have Lifespan, its CEO, Anne-Marie Cook, and her team doing their magic every day. But they're unconnected to the healthcare delivery system by and large, when they should be an integral part of the healthcare team to teach us about the important needs and partner with us in meeting them for older people. Over the last 15 years, the SHARE Alliance partners have trained staff to screen for detection of depression, anxiety, and suicide risk in their clients, to treat common mental disorders using psychosocial interventions, and coordinate their work with primary care and mental health care providers. We also have tested impact on depression, loneliness, and well-being of peer support, volunteering, having pets, and there's more to come. The SHARE Alliance is on the forefront of older adult care by building bridges between service systems, health and human services, that ordinarily exist in separate silos and by doing so, providing evidence that their collaboration in the care of older adults with mental illness yields better care and better outcomes. Thank you.
Hello, I'm John S. Walker. I am the coordinator of the Clergy Mental Health Collaborative. That is a group of 8 to 10 churches and their leadership that we call upon once a month to help project programs within the context of the Department of Psychiatry. Now, you're probably asking, why the church? Well, we have invited many clergy to participate in this aspect, 10 to 12. Most have. They have agreed to do so. But everything that we've talked about with respect to issues and problems and events are just about in the circle. Now, within the church itself, within the Black church particularly, all of these issues are paramount. So we have the leadership and we have the means to really deal with them effectively. And the support that we get from the school has been amazing. So we're off and we're running, and we welcome you, and we want you to please be involved with us. We have been together now as a group for at least 3 years, and as a result of our coming together, I think that we have really closed the door on a lot of information that has been necessary for us to retain, necessary for us to collaborate with one another. The whole hope of our programming deals with how the churches are going to manifest themselves with respect to the evils that are represented in various aspects of those things that we tackle. Community awareness is very much a part of our concept, and the churches are very important in helping us spread the word with respect to all of these things, so that when we give events, when we have events rather, such as panel discussions or seminars, or when we call attention to the fact that these are what we should be dealing with, it helps us to grow, and it helps us to fascinate whoever we do talk with relative to the issues that are involved. Now, in terms of what we have done, we are just excited about the awareness that many of us feel, because it wasn't there at the beginning, but now it is there. And now we have resources. We have resources that the Department of Psychiatry offers, and all in all, we are very optimistic, very hopeful that this is going to work.
The mission of our expanded school mental health model at UR Medicine is to build the capacity within local school systems to support youth with behavioral health needs, while also providing high-quality clinical care in family-friendly and school-based settings. Our schools are often looked upon as epicenters of their communities, serving multiple roles as academic and recreational centers, community food pantries, health clinics, and increasingly counseling offices. As a consequence, educators are increasingly called upon to play roles beyond the academic instruction that they're not necessarily trained to perform. One role that's become more prominent in recent years is in supporting students' social and emotional health and in wellness. Educators are increasingly likely to encounter students with social, emotional, and behavioral health difficulties that serve as barriers to learning, especially following COVID. While some difficulties may be minor or short-lived, we know that nearly 20% of youth face difficulties that are severe enough to meet criteria for a diagnosable mental health concern over the course of their childhood. When behavioral health concerns are addressed effectively in educational settings, we know that youth have higher and more positive academic outcomes, improved attendance, fewer disciplinary encounters and referrals, among other positive outcomes that last the lifespan. This has led the Surgeon General to identify schools as a core frontline partner in both recognizing and addressing the social, emotional, and behavioral health needs of youth and supporting their families. Our expanded school mental health model is one framework in which community behavioral health providers can support school efforts in promoting students' behavioral health. Our initiatives utilize URMC behavioral health providers as partners with schools and families to augment, not replace, existing school supports, to build schools' capacity to support children's behavioral health needs, and to provide a more comprehensive array of care within a school-based setting. Importantly, our model operates across the full promotion, prevention, and intervention continuum, and we find that these supports are most effective when incorporated into schools' existing multi-tiered systems of support. Our comprehensive services include statewide capacity building initiatives that build the quality of school mental health programs against nationally recognized benchmarks. We offer evidence-based child behavioral health trainings for educators and school mental health staff. We support with consultation and in technical assistance for staff who are supporting students with more complex behavioral health concerns. And we offer school-based intervention services such as clinical assessment and treatment within a comfortable and family-friendly school-based setting. And together, this framework provides an opportunity for schools to expand the behavioral health capacity of their system through enhanced staffing, training, resources, skills, and knowledge through this important school-community partnership. At a systems level, this capacity building model positively shapes school-wide behavioral health policies, programs, and practices that successfully promote students' social and emotional and behavioral health needs. Our supports also promote the generalization and maintenance of treatment gains, enhance capacity for prevention and mental health promotion in school settings, and offer supports for youth and families who are attending school in a comfortable, family-friendly environment.
As a lawyer, I often experienced working with clients who were facing mental health burdens while they were engaged in court proceedings. This window in 1999 to what people seeking court orders needed for their physical and mental health launched a very long trajectory of community and federally funded research in partnership with the New York State Office of Court Administration. The first project, as I mentioned, was a survey from 1999, which led to a randomized control trial in 2002. The randomized control trial taught us that based on a 3-arm study of screening, assessing, and referring individuals for mental health care when they were facing depressive symptoms wasn't enough. What we learned is that we needed to be on site and we needed to provide services in real time. That study in 2002 led to the creation of an expansion of the socio-legal clinic where we offered screening and assessment for people who were coming to court facing depression. That project, along with the intense work from our patient leadership team, Gina, Michelle, and Elaine, led to the opening of the HEAL Clinic in 2016 in the Department of Psychiatry. The HEAL Clinic is a very unique medical law partnership wherein, right on site at the University of Rochester, providers and patients can self-refer to HEAL for a biopsychosocial assessment, which is done over a REDCap platform, and it includes offering the patient resources they may need. Through a patient-centered approach, patients can utilize the legal track wherein they can meet with attorneys. They can also secure a protection order right from behind the hospital walls, or they can seek mental health help or be engaged with a doctor to provide help that they may need for their physical symptoms as a result of the violence they've experienced. Our community partners for this included, again, the New York State Office of Court Administration, but also attorneys and providers locally, Willow, which is our local domestic violence provider, Resolve, which has now merged with Willow, Sathi, which caters to South Asian victims who have experienced violence, and the Rochester Police Department. This medical law partnership is unique. We believe that orders of protection can serve as part of a person's healthcare plan. We know from research that has been done that orders of protection can reduce future violence if they are carefully crafted, issued, and enforced. When people are engaged in the court system, it is not just often a legal problem. People who are court involved often have comorbid social determinant of health challenges, including homelessness, food insecurity, transportation barriers, and have conflicts within their family or business settings. In our department, we have been able to partner with organizations to not wait for people to come behind the clinic walls to serve them, but rather reach out. We thank our community partners for trusting us, and we look forward to this discussion unfolding. Thank you.
I'm Stephanie Gamble, Associate Professor in the Department of Psychiatry and Deputy Director of VA's Center of Excellence for Suicide Prevention. My father is an Army veteran. My uncles proudly served in the Army, Navy, and Marines, and my grandfather, who turned 104 in February, is a decorated Army World War II veteran. For me, caring for veterans is both personal and professional. I've been part of the department since the early 2000s. Now, during that time, the department had already established a stellar international reputation in the study and prevention of suicide. So it makes sense that when Congress established a need for a National Center of Excellence for Suicide Prevention dedicated to reducing the morbidity and mortality of suicide among veterans, VA leadership looked to suicidology expertise within the University of Rochester's Department of Psychiatry. Senior leadership in the Department of Veterans Affairs worked closely with psychiatry leadership and faculty to found the COE for Suicide Prevention in Canandaigua. Notably, Dr. Eric Caine helped to lay the foundation for what is now the COE. Since its inception, psychiatry department faculty have served as executive directors of the center, specifically Drs. Carrie Knox, Ken Connor, and our current director, Will Pigeon. Department faculty also serve critical consultative and investigator roles across both the Department of Veterans Affairs and the Department of Defense. More recently, what started as a partnership in science and scholarship has taken an important step towards service to local veterans in the greater Rochester area. As part of the department's DICE committee, department leaders have brought together a dedicated group of individuals across psychiatry and the VA to examine how we can enhance clinical services to better reach and serve veterans in the region. I'm honored to be a part of the panel today, and I'm excited to be a part of the future of this department to bring Meliora, the pursuit of the ever better, to veterans and those who love and care for them.
All right, I'd like to welcome our panelists with us here tonight into the Zoom room so that we can further this discussion on how the biopsychosocial model has influenced the great work that they've been doing in their community partnerships. And so just a friendly reminder as we get started that we absolutely encourage our audience to ask questions or to comment on the conversation and the dialogue that we'll be having here tonight. And so we're just waiting for some more of their beautiful faces of our doctors to pop up before we begin. Well, first of all, I just want to say, once again, I'm just blown away by the remarkable work that you all have been doing and continue to do in our community. And so I'd like to start off with just a thematic question. Anyone who would like to start and kick us off, feel free to jump in and answer. But considering you guys all work with such a diverse populations, we're talking from the young to the old, we're talking in the social services to the legal side of things, to our spiritual and religious communities. So tell us a little bit more about how the biopsychosocial model has influenced your approach and the work that you do with the populations that you serve in our community.
I could jump in, Leah. And first of all, thank you for hosting us tonight. It really is a remarkable story, I think, about how the department has developed truly novel ways of reaching out into the community. I mean, people may not appreciate how unusual so many things that the biopsychosocial model has led us to do really is. With regard to your question, I think there's a special, at least from my perspective, take on the biopsychosocial model and its influences in geriatrics, because perhaps like kids and certainly for older adults, there is no real understanding of health and well-being without understanding the social context in which it happens. In geriatric psychiatry, for many years, there was a very heavy influence of the notion of integrated care, where mental health and physical health care were combined, because older folks didn't go to mental health care providers. They go to their primary care doctor. So it was those two. But there's a big gap there when you stop and think about it, because mental health, physical health, where's the social? We've learned a lot about the impact of social determinants of health, but it must be incorporated with those other two to really, I believe, result in truly integrated, fully integrated and effective care. So the biopsychosocial model really captured, for many years before there was actually a specialty of geriatric psychiatry, the fundamental idea that it's not any one, it's physical, mental, and social health.
I might add that I think the challenges of the 21st century and the late 20th century forced us to think, how would the biopsychosocial model evolve? It was really developed to think about an individual, the patient in the clinic, in the hospital. And I think what you see tonight are a group of people who all cherish that, but also recognize that it doesn't always fit the needs as it was originally defined, which was really in the 1940s and 50s, although it was published in the 1970s. It was really conceptualized over a period of 20, 25 years. But that was in mid-century. And late century and new century really challenges us to think about different diverse populations and where they live, where they work, where they can be encountered. And that can't be done alone. That can't be done simply by health professionals. It has to be done in partnership with partners who are uniquely qualified, the people of communities, and whether it's veterans or the court system or schools or the faith communities. It requires that we as trained as clinicians, very much in a very traditional way, perhaps, are forced to grow and evolve along with those challenges.
Yeah.
Go ahead.
No, by all means, Dr. Haight, jump in.
Thanks. So I'm just gonna build upon what Eric just said. The work that we've been doing in the court, obviously Reverend Walker's presence here, some of our publications have had biopsychosocial circles with an additive circle for faith. And, at the courts, when we're working in an area of intimate partner violence or family violence, and people have a commitment to their faith, marriage until death do they part, for the suicide prevention research we've done in connection with domestic violence, we've interviewed, parent survivors, sibling survivors. A lot of people mention the role of faith in their health, and faith meaning different things to different people, connections to spirituality that is internal or maybe reflected through a connection with nature, faith for them, which is the practice of a particular religion with an organization or an institution that may or may not be recognized. So I think that as we consider the evolution of our work in the biopsychosocial model, to consider, as Eric said, when we're working with different populations, people with different lived experiences, people with different identities that cross geographies, that cross age, race, religion, I think it's interesting to consider how we think about the model and its application to the people we're serving when we hear unsolicited in our work the role that faith plays in the healing of the mind, body, and soul for people.
Absolutely. Reverend Walker, would you like to speak on the role that you've seen the faith community play for the individuals that you serve? And I think it is interesting, Kate, too, and what has been said already about how meeting our patients and their families where they are in context makes such a huge difference. So, Reverend Walker, would you like to tell us more about what you do?
Well, let me let me begin by simply stating that the situation relative to people and church has changed drastically over the years. Early on, the community was controlled basically by the church and other religious assemblies. But when the great fallout occurred, and I will say that during the civil rights movement, so-called, that's the point of declaration that I'm making at this point. At that intersection, when people no longer trusted the church, they no longer felt secure within the bounds of the church, they no longer gave themselves in sacrificial means to the work of the church in the world, so to speak. That's when those of us who were in any way developing ways in which the church could become more relevant, more institutionalized to deal with these concepts, to deal with these perceptions, to deal with these problems and issues, that's when the whole roof began to fall. Much of it is a result of the church having to make statements such as they are present for work among individuals who have problems that we are not speaking to. In other words, only spiritual problems, but they fail to understand that the majority of spiritual problems have an underscoring, has a way in which we have to understand that these are, in essence, spiritual, that there is no problem affecting anyone, scarcely, in the world, that there is not spirituality hinged to it. The work that the Clergy Mental Health Collaborative is doing, it attempts to address those, but we have to be very careful in that we have to have people involved who believe our testimony. We have to have ministers involved who are preaching and teaching from this standpoint, this perspective. And we have to really work very, very hard as equal partners with the community and all of this. I think that one of the better things that we have seen developing although it's been somewhat slow, it's still nonetheless there. And that is the piece of material that we cling to as being collaborative, as being a part of, as being in some degree a partnership. I think that reciprocity is one of the largest areas of hope that we have. I do this to the best of my ability, you do yours to the best of your ability. And then we will apply them both, if we can, to the spirituality that lurks underneath all of this. I would be, as a minister, I would certainly be out of focus and out of training were I to submit to the fact that this does not have a spirituality connection. But I don't do that. I'm careful enough to avoid making statements that are irrelevant and that have no mix at all with what we are attempting to do. We are attempting, as leaders of the community, we are attempting to position ourselves as leaders. We are attempting to do the best that we can in the way that we can to destroy stereotypes, to destroy anything that is committal to offsetting what we have done.
Reverend Walker, thank you so much, because you brought up such a good point in terms of the partnerships that we get to create and establish to be a bridge for marrying the two from our clinical standpoint into our community. I'm wondering if, Melissa or Stephanie, if you can speak to what your experience has been in bridging that gap with your perspective, populations as well.
I think the biopsychosocial approach is just so critical to child and adolescent psychology and psychiatry, because if you think about an 8-year-old kid or a 12-year-old tween or even 18-year-old, who are they without their families? Now, you can say that to an extent of any age range, but especially kids who are so dependent on their families. We really need to be thinking about their social environment, including families. And also, oftentimes, kids are spending more time in their schools and in their educational settings than they are at home, more waking hours. And when we're thinking about ways to support those youth and families, we know that the vast majority of kids who are going to receive needed behavioral health services are going to get those in the school setting. 80% of youth who need behavioral health support are going to get it in schools. It's a really logical place for us to partner and us to leave our offices and offer additional support so that we can really be at the front lines supporting our educators who are working with our kids on a daily basis.
I'll jump in here too, Leah. Thank you for the question. One of the benefits, I think, about training in the Department of Psychiatry is that the biopsychosocial approach is ingrained in you, and that you see the world, I think, through that special lens. Not only a lens to see how problems develop, but a lens to see opportunities for solutions. And I think this biopsychosocial approach has a particular relevance or particular meaning when we're thinking about preventing suicide, because suicide is multifactorial. And it's particularly relevant with veterans when we think about all the modifiable risk factors, biological, social, psychological, that can happen over the lifespan of a service member. Not too disparate from what Dr. Heatley was saying with regard to an 8-year-old. We have these trajectories. And so when we think about risk and we think about solutions, I think we have to take that trajectory, and Dr. Caine and Dr. Conwell have talked about this as well, that trajectory approach, and how biopsychosocial aspects of one's life, they change and they're modifiable across the lifespan. So when we're thinking about solution, Dr. Caine mentioned that the touch points might differ depending on where someone's trajectory is leading.
Oh, I love that. That was such a great way, Stephanie, to kind of bring everything back together. And, you know, I'm just thinking a little bit about you all, I mean, for either a number of years or decades have been working with your community partnerships. And I think, as you mentioned, Stephanie, like it is very hard to unmarry and to pull ourselves out and extricate ourselves from the biopsychosocial model and approach in the work that we all do. I'm wondering what the influence of COVID over the last couple of years and the fallout that has happened in our behavioral health and mental health field have had on how you guys are all approaching the work that you're doing with your populations. It's a big one. I'm just going to throw it out there. And then just a reminder too, for our audience, again, feel free to put those questions or comments into the Q&A chat box as well.
I mean, I can jump in. I think COVID really illustrated the power of how the social world really impacts behavioral health and biology. And when COVID hit, for many of our families and our kids, the bottom dropped out from under them. And schools were shut down for months and were disrupted into this year. And we have kids and families who are still struggling with quarantines or disrupted educational and learning opportunities and disrupted social opportunities. And we are seeing this play out in a national youth mental health crisis that is linking to a crisis in care in our mental health community as well. And so I think it's really, it's proven the model in many ways. And also it has illustrated the need for us to be able to support communities where people are and where they're living, and help rebuild what is really a critical infrastructure for fostering resilience in people and wellness. We need community. We need social interaction. We need a lot of these faith groups and really important community-based resources to develop resilient people and resilient children.
Going beyond our community and looking across the world, I think the other thing COVID has done is to really illustrate, sometimes very sadly, the differences in public health. Public health is really a collaboration between health systems, government, and communities. And in some communities in the United States, this has worked very well. In others, it's really broken apart. And certainly the United States has, suffered the highest death toll of any country in the world. And other countries have, even some that are quite similar, have death tolls that are, sort of 1/10 of the rate of the United States. So COVID has been a painful lesson in things that we can do and things that we haven't done. And one of the things I hope it in time becomes is a teacher for us. Now, the Department of Psychiatry, for example, was really quite remarkable, under the current leadership, Ben Lee, and people like Michael Hasselberg and Yeates, Conwell, and others, in senior leadership positions, to turn very quickly, as Leah, I'm sure you know, to telepsychiatry, telehealth, and all those sorts of things, and was a leader in the medical center and really was uniquely prepared in some ways to do this. But again, that doesn't really reach into communities in the same way that we would want. It's really with people who are either established in care or come to us seeking help. So I think COVID in some ways impeded lots of the kinds of efforts that were underway. And I think one of the real challenges now is to get them going again in a way that benefits, I'm putting that in quotes, from the lessons that we've learned. It's a painful lessons, but maybe we can grow through those. As I say, the department did a really remarkable job, and hopefully this will provide some new foundations.
Yes, I absolutely hope so too. And Kate, would you like to speak on this?
You're muted.
You're
Kate.
muted.
Thank you. I'm going to pivot just for a minute because someone has entered a question, Simeon, about the use of law and how it can restrain freedoms. And you can all read the question perhaps yourselves. I just wanted to speak for a moment about the intersection of law and mental health for a moment, because as we at the HEAL Clinic pushed law behind our clinic walls and pushed mental health within to the court systems, it is a way other than forensic psychiatry, which normally was examining competency and whether one was able to participate in their own case and whether one could have liability for what they did. The protection order that we look at in our systems at U of R are protection orders, which the petitioner, the patient, drives. The patient decides whether they want it. They decide what provisions within the order they're looking for. Are they looking for their partner to get mental health or an evaluation? The family court orders do not, unless a second order is filed, have the ability to incarcerate the person that's the respondent. But we see it as a public health tool because the research shows a large reduction in future assaults, up to 70%, depending on whether the order is carefully drafted and enforced. So I think that our goal in the HEAL Clinic, as it was created by survivors, was to offer remedies. And the remedies were to offer a variety of reliefs. Not every survivor wants to involve the legal system or a spirituality team or a doctor or mental health for that matter. What we found was by putting the control into the hands of the survivor in our first PCORI study, we reduced self-reported domestic violence by 50%. So I think that that's important. The reason I raised my hand before Simeon asked the question was to talk about what Melissa had said, because while her efforts became so important during COVID, we also saw an increase in child abuse and domestic violence. And that was internationally, that was not a national phenomenon. And as we saw people unable to leave violent relationships, unable to seek safety, I am really amazed at the HEAL team, how they pivoted to move to telehealth while considering the safety of the person on the other side. We had another partnership where people were mailing out headsets to survivors that they could put on when they were talking to their provider so no one else could hear what the provider was saying. And we were coaching providers to ask questions that were yes and no answers. So I think that what COVID taught us was that we can break a lot of barriers down for people. We can break down the transportation barrier, the parking barrier, the babysitter barrier. If you're an hourly employee, you can have a therapeutic session, maybe, outside or sitting in your car. You don't have to take a day off of work or a half a day off of work. So I think that it opened up opportunities to think differently, as tragic as it was. And I think the challenge is, how do we move forward, not just in the clinical or legal spaces, but in the policy spaces? A lot of young people I work with have said they can't continue in their therapy because their parents' insurance is out of Indiana, and now that different provisions have gone away in their state, they can't be seen outside of their state. So I think we have to be thinking at a national level. How do we take what we learned that worked? How do we correct what we learned that was a problem that we knew maybe existed, but it was exacerbated?
Thank you so much, Kate. And Yeates, please jump in, and then we do have a question from the audience.
Yeah, I saw that. So I'll defer to Dr. Walker quickly here to say only that one of the things that COVID has taught me, underscored for me, is the strengths and resilience of the community and older people in particular. And a lot of people were very fearful, me included, that because of the vulnerability of all of us to social isolation, that suicide rates might rise as a function of social isolation in a COVID era. That hasn't appeared to happen. Now, it's still early on, and things may change, and we need to be very, very alert, in particular to those who are vulnerable for other reasons. But in the face of COVID, older people, by and large, have done pretty well. Because they have resources to draw on through many years and many generations of managing and developing their skills in managing even crisis situations. So bottom line there is that I think we have so much to draw on as healthcare professionals in the strengths of the communities of the people that we serve. And it's another thing that a biopsychosocial model has taught us.
I want to interject before we get to Reverend Walker, the other aspect of the question about the potentially restrictive aspects of psychiatry, law, and religion. And of course, there is always a balance between sort of regulatory functions and individual liberties. And mental health, for example, we are given the authority by society to take away someone's civil liberties, commit them to the hospital against their will. And so one of the things that the biopsychosocial model and a community-oriented model calls for is that people of conscience work very hard in our fields to not use these delegated authorities in a cavalier fashion. Now, I can't defend all of what's happened in psychiatry, for example. I'll speak more to that. But on the other hand, I think that a lot of us have really tried to bring this to better discussion. And the more that we interact with people who are outside the health systems with diverse points of view, the more likely we are to be able to be conscientious as well as people of conscience. So there's no fixed understanding of how we interact with faith communities or the law, but rather a recurring questioning and examining, so that we do this in a way that promotes, as Kate Cerulli said, the best as it's driven by the individual perceptions and needs of the persons that we're working with and their communities, as well as their families. So I'll defer to Dr. Walker, but I wanted to throw that in there.
Eric, no, thank you so much for jumping in on that, and for highlighting how critical it is for us to maintain these community partnerships, so that for lack of a better word, in many ways, we get to uphold and operate also from a lens of cultural humility and the treatment and care of the patients, families, other community members that we serve. And so I do have a question from Jay Esther, and this is for you, Dr. Walker. So I'll read it for you. The question is, how do we deal with the biopsychosocial model in the African-American church community in a context where the end time prophecies are being promoted, and many of the things that impact mental wellness are interpreted in this context of end times? How do we help parishioners to understand end times notwithstanding, that our health is important and we need to seek those resources that will allow us to become healthy and whole? Woo, that's a big one, Reverend Walker. Oh, you're muted. We'd love to hear you. Hold on, you look for the little speaker down in the corner. If it's red, you are muted.
Okay. All right. Thank you. I think that should clear it up just for a moment. But the question, how does the church react in a different way? And I think that the term different way is what we are very interested in at the moment, simply because once you begin to hang on as if there is nothing beneath you, once you begin to hang on with no hope of recovery. Once you begin to just stay there, immobilized, things are not going to get better. Our people have to recognize the fact that God has promoted, God has stimulated, God is in the middle of whatever goes along with change, especially change for the good, change for the better, change for the progression of what we stand for. Always just not get it any longer. I deal mostly with the poor. And the poor, they're hanging on because of a trust factor. And this trust factor is very hurtful, simply because much of it is true. However, we must begin to look beyond the trust factor problems and direct our attention to the healing of individuals. I am very much upset. I am very much drawn to depression because of what occurred on this broadcast at the beginning when several people stated what had occurred in Texas. I had not heard of it, but it opened the door for much of the depression and much of the flirtation of the mind with respect to this. What we have to do is to move ahead. Move ahead. Move ahead. Don't wait for others to make decisions for us. We must move ahead and make those decisions ourselves. I think that that's the only way that I know how to respond to the question, is by just doing much better than we have been doing at a more accelerated pace. Now, one other thing, and this is short, and this is minor. Well, it's not minor, but it is short. Dr. Caine mentioned at the beginning of his presentation just a moment ago of how much he has been brought to the realization that persons in the field of medicine have dedicated themselves primarily to this task. Even persons whom I have known over the years who had different types of motivations have ceased having those motivations and now are concentrating on the physical and mental well-being of those who are desperate. So I share that with you, Dr. Caine, that every time that I get a chance to offer what I feel has been part of the declaration of change, that is a major part of it. The fact that we do have people in the field of medicine, in the field of healing, in the field of mental and physical healing, persons who are connected directly to change. That's about the best that I can do with that one.
That was more than enough. Thank you so much, Reverend Walker. Stephanie, I want to pivot to you. If you could talk to us a little bit about what you've been seeing with the Center of Excellence and the veteran populations that you've been working with.
Oh, sure thing, Leah. I think maybe building on Kate's example about how one of the silver linings with COVID is that it gave folks, I think particularly folks maybe with a biopsychosocial mindset, the ability to be agile in very challenging times. And within the VA, I think even before COVID presented its challenges, Dr. Caine talked about the public health model and how it was applied to the Air Force. But he was sort of humble in the fact that the public health model that he and Dr. Knox introduced has been adopted by not only the Department of Veterans Affairs, but the Department of Defense. the public health model serves as the framework for the national strategy for preventing veteran suicide and for reducing suicide among service members. And building on that public health model, the VA in about 2021 first started introducing a dual focus on establishing not only a strong empirically based framework for addressing suicide prevention clinically through clinical services, but it embracing the public health model, recognized the need to double the workforce in suicide prevention by establishing a workforce dedicated to community coalitions in the community. And so fortunately, I think this plan was beginning to be rolled out even before COVID. And so it allowed VA to continue to be agile in addressing the needs of veterans in the community by establishing this program to, as I mentioned, kind of essentially double the workforce by adding community engagement specialists. And Leah, you can probably relate to this, community engagement professionals to reach into the community, to establish coalitions. And it doesn't apply just to suicide prevention. I mean, it is suicide prevention, as Dr. Conwell noted. Any upstream intervention the idea is that it's going to disrupt trajectories towards suicide. So by establishing these community coalitions in suicide prevention, we essentially can create these local, specifically targeted pockets of upstream intervention that serves the needs of veterans and communities, no matter where they are in the country. So that's something that I think, again, is a silver lining in COVID, but it's built on the framework of public health models of suicide. And I don't know if Dr. Caine wants to say more about that.
Oh, I think you're wonderfully articulate. I don't think I need to, how should I say, gild the lily. Thank you.
Well, thank you. Yeah, thank you so much for speaking further on that, Stephanie. And we are approaching the end of our webinar tonight. And so before we close and I close everything out, is there any one of you that would like to speak a little bit on, just very, very briefly, on your hope for where you see the biopsychosocial approach moving in your particular sector? We'll do kind of a lightning round with it.
Yeah, I guess I'd like to see more of an integration of health at the courts in terms of understanding the consequences for mental health and physical health of violence in people's lives. And when people are upset in court, or they cry, or they have trauma issues, I just saw a judge, scream at a woman who started to cry when she had her mom for the first time recognize she had been abused as a child by a person. And I thought that was an appropriate response to cry. So I'd like to see education, professional education for the integration of the model. And we have buzz language now that, court should be trauma informed, but people don't really sometimes understand what that means, I think.
I'm certainly hoping that medical centers understand that if we take our own or other major academic medical centers, they're really disease treatment centers as opposed to health centers. And if they're going to evolve towards health centers, they have to work with communities, and they have to understand that the biopsychosocial model, the term social there is not just a person's experience, but a community's experience. And the factors that drive health and well-being as well as illness. And Yeates, Conwell referred to social determinants, whatever term we want to use, will our and other centers embrace that mission? I don't know the answer to that, but I certainly hope that they do.
I'd say the same, Eric. I guess that's no surprise, since we work closely together on these issues, which we regard as vitally important for so long. There's a tendency, I think, for all large organizations to try to manage all aspects of their work. And as I said in the little video clip that we had the opportunity to do before, working with an organization like Lifespan really shows how important it is to acknowledge and honor the experience of the people who are working in the community. The medical center isn't going to be able to recreate that. It exists already in an excellent form in the community, and that's the resource that we as the health system ought to be linking, partnering with, and supporting, so that we can all work together on that. I think everybody on this panel has probably a very similar take with the organizations that they work with. That's where the strength lies.
Yeah, very much building on what Yeates is saying. I really envision the future of our school mental health or programs as partnering deeply with these community organizations that are so strong in supporting our kids and our families already, and enhancing their ability to do this good work. We don't want to go in and replace or take over mental health supports in our school settings. We want to enhance the good work that is occurring already, and also supplement when needed, and when that extra level of expertise is required. One thing I did right before this call, just to illustrate this point, is, in response to these terrible events unfolding in Texas, I drafted an email to over 100 community school partners in the greater Rochester region that really highlights the exemplar national resources that sadly exist already because of Sandy Hook and Parkland in responding to school shootings. And I have great faith in our school partners that they will be able to take those resources and run with them. And I really envision our job in making it easier for them to do that in a trauma-informed, culturally responsive way. I'll drop some of the resources in the chat before we end today.
Well, thank you so much. And I know we are so close to wrapping up. And so Stephanie, do you want to add anything really quick, please?
Just to highlight that I think one of the strengths of the department is the fact that we've helped to establish frameworks. Kate's done an amazing job coming up with a framework that courts can use. And I think just echoing the point about not taking a top-down approach, in that, we have this expertise and here, use it. It's really about partnerships, and partnerships with a framework that can be molded in communities to fit the needs of individual communities.
Awesome. Remarkable. Panelists, I just want to thank you so much for coming out and sharing your experience and your community partnerships, how the biopsychosocial model has continued to influence your work. And I want to give a big thanks to our audience for participating today, to the 75th anniversary committee, Zena for setting all this up, our tech wizards in the background, Steve Fasson and his team, Brian Chang, Carrie Hinman, and to let all of you know in our audience that we do have another webinar scheduled to come up on Tuesday, August 30th, and that is going to be from 6 to 7:15 p.m. on the future of biopsychosocial caring, discovering, and learning, where Dr. Ben Lee will outline a vision for the future of our department and reimagining the BPS model to meet the challenges of today and tomorrow. Thank you all for coming here tonight. Be well. I pray for you, your families, and everyone else who is so indelibly impacted by the violence, but I do believe in hope, and I do believe in our communities. So thank you all for being here.
Thank you, Leah, for hosting us, and the team for planning it.